Thank you, Amy, very much for that introduction. Although it is true that my first job was in 1997 in this area, I did go away and do some other things, and I've come back now, and I just want to thank Steve and Mary Jane and so many of you in this room for giving me such a warm homecoming to both the city of Los Angeles and this field. I'm really excited to be here to talk today about behavioral economics. Okay, so when we think about what behavioral economics is, so I'm going to be just giving a little overview of what behavioral economics is and talking about a few key concepts and hopefully sparking a conversation or a discussion about how we can apply some of these principles to the work that you guys are doing. Okay. So when we think about what behavioral economics is, we like to think of it as an intersection of neoclassical economics, which is a fancy way to say economics, and psychology and other fields. So it's sort of bringing together concepts from those fields to bring new insights into how to affect people's behaviors. So neoclassical economics would say that we are all rational actors with fixed preferences who make decisions having full access to all relevant information, and we consistently, over time, make decisions that will maximize our value. But if that were true, then why are we overweight, undercapitalized procrastinators? Those of us who look at behavioral economics looked at that, or look at what people do. Famously, Amos Tversky and Danny Kahneman saw some violations of these rules and said, you know, we actually act irrationally all the time. We're capricious, we care about reputation and how we're doing compared to other people. So consider this young gentleman here. He has just received an orange popsicle. He seems pretty happy with that orange popsicle, but things seem to look a little bleaker and a little bit unfair when he sees what his sister has gotten. Or as my husband likes to say, sisters ruin everything. If you can't see it from in the back, she's got a giant ice cream cone. An economist would say, an orange popsicle is an orange popsicle. It should be no less delicious because your sister has an ice cream cone, but we all know the context in which we make decisions and the reference groups we use do make a difference. So, the difference between how neoclassical economics says people will act and how people actually act is what is described by behavioral economics. So I'm going to talk about 3 different concepts today. There are many heuristics and biases we could talk about, but for the sake of time, I'm just going to talk about 3. Myopia, loss aversion, and overconfidence. And these concepts and many others have already been successfully applied in a lot of other fields to help encourage positive behaviors, like Amy mentioned, saving money, conserving energy, and also in health-related fields like obesity, heart disease, and substance abuse. So I'll talk a little bit about these concepts, what neoclassical economics would say, what behavioral economics would say, give a little example of how it's been applied, and then maybe give some suggestions about how we might apply this to the work that you all do. So, hyperbolic time discounting, or myopia, sort of looking at nearsightedness, right? Neoclassical economics would say that people can rationally evaluate rewards, and they discount the cost of time in a linear and consistent manner. Behavioral economics says that it's actually not linear. The way that people look at things is actually they place too much value on a small reward now, like eating this delicious cupcake, and in return will give up a larger reward in the future, like fitting into your itsy-bitsy, teeny-weeny yellow polka dot bikini. This also applies to other behaviors, risky behaviors like sex without a condom, or even things that you might avoid, like eating your vegetables. So there have been a lot of applications leveraging myopia. So some of these that you might have heard of is contingency management or conditional cash transfers, which actually comes from the field of psychology, but is very relevant to behavioral economics. And some of the programs that we're talking to today, like Amy's project on Project Engage, on giving people incentives. So contingency management and conditional cash transfer programs generally are a set of tools or methods where people are given incentives, often financial, in return for some kind of positive behavior. So in substance abuse treatment, you might get money in exchange for returning negative urine samples. And in Latin America, there are a lot of social welfare programs where families are reimbursed or given incentives to get their children into vaccination programs, well-care child visits, and keep them in school. So just because this plenary session is called Beyond Contingency Management, I thought I'd give you a little flavor of what contingency management is, but talk about some other areas, areas that we apply behavioral economics that you might not have heard of. So another area that myopia has been really applied in is in healthy eating. So in food labeling, the idea of putting calorie counts on menus really brings forward the salience of how much impact you're having on your body. So when you're looking at the McDonald's menu, sorry, I don't mean to bring up brand names, a fast food chain menu, and you see that calorie count, the salience of the future being able to fit into the bikini may be more salient to you than the French fries. May help you, nudge you towards a better health decision. Another area that this has been used in is in sort of buffet type studies where they show that if you put vegetables at the beginning of the line, people eat more vegetables. If you put candy in opaque containers versus clear containers, people eat less candy. So some ways that you might want to engage some of these ideas would be either giving small immediate rewards for intermediary behavior, kind of like contingency management, or increasing the salience of future consequences or rewards. So sort of that same old idea of putting the picture of yourself on the refrigerator or hanging the bikini in your room, something like that. Okay, so the next concept is loss aversion. And neoclassical economics would say a gain or loss of the same amount should cause an equal amount of pleasure or pain. But we all know, and behavioral economics does say, that losses actually loom larger than gains. The pain of losing is more than the pleasure of winning. So I like winning, but I really hate losing. And this can even be in a case where the thing that you're getting if you're losing is still pretty good, like an Olympic silver medal. One application of loss aversion was a study done in Chicago schools that were having very strong performance issues, where they tried to do a pay for performance intervention where they gave teachers a bonus tied to how well the students did. That is not necessarily an innovative idea, and many studies have shown that giving teachers bonuses in turn for performance doesn't actually do that much. But this study had a little twist on it. So half of the teachers got their bonus at the end of the year. The other half of the teachers actually received their bonus at the beginning of the year and were told, if your students reach these performance standards, you will keep the bonus, and if not, you will have to return the bonus. Right? So they basically placed the teachers in sort of a loss frame, a sort of idea of losing this bonus. And in this study, the teachers who had to return the bonus at the end of the year if their students didn't do well, their students did 2 to 3 times better on the end metric, which was a math test, which was an outcome that was similar to reducing class sizes by about 1/3. So it really did have a strong impact. Leveraging an insight like this might give you a design idea to either put rewards at risk if behavior doesn't change, or maybe frame consequences as losses rather than gains. Okay, how am I doing on time? Okay. The last concept I'll talk about is optimism and overconfidence. Neoclassical economics would say that people are accurate in predicting their behavior, and their behavior will be consistent in the present and the future. Behavioral economics says that people have too much confidence in their judgments compared to their actual accuracy. So everyone thinks that they're a better than average driver. Everyone thinks that they're funny, but that is not necessarily possible, right? Also, people are too optimistic when they're predicting their future behavior. So when you start a diet, you really think, this time I'm gonna do it. I'm really gonna lose that weight this time, or quitting smoking, or any kind of behaviors you really wanna change. So the kitten sees the lion. One study that leveraged optimism and overconfidence was one by Leslie John and colleagues, Kevin Volpe and them in Philadelphia, where there was a weight loss study. And I like to call it put your money where your mouth is. But participants basically bet on their own weight loss. So at the beginning of the month, they were given the opportunity to invest an amount of their choosing into an account, and then they were sort of tracked over time about their weight loss. If they achieved their weight loss goals at the end of the month, the money was matched. If not, they lost their money. And the people who did this investment arm, they actually lost 13 to 14 pounds in those conditions compared to 4 pounds in the control condition. So they really, it was a pretty good nudge towards losing weight in that case. So some insights that might come from that would be designing commitment contracts with goals contingent on your expected success. When you start out the program, when you have the most optimism and you really feel like and you have the highest level of commitment. Also, this is another one where being optimistic and having overconfidence is not necessarily a non-adaptive trait. If we weren't optimistic and overconfident, we probably would never invent anything interesting or do a lot of things that, that involve risk-taking that we maybe shouldn't necessarily do. But if you did want to reduce people's unrealistic optimism or overconfidence, one thing you can do is give people feedback on their accuracy. So I think that's it, and I'm going to hand it over to Sebastian, who's going to talk about specific applications of ideas like this to HIV prevention, treatment, and care. Yeah.
Sure. So good afternoon, everyone. My name is Sebastian Linnemayr. I'm an economist at RAND. And I'm here to talk about why these concepts that Kim just so brilliantly described and so colorful, that my slides, of course, cannot match, I'm sorry for that, why this actually may matter for us doing HIV research. And it might be shocking to you that after this presentation, where I saw most of you nod and, oh yeah, I've tried to lose weight, but somehow I couldn't do it, I'm wearing a Fitbit, these sort of principles have never been applied to HIV research. And so I will first of all explain why I think it really matters for HIV as a chronic disease that has a lot of characteristics that make it likely that people are prone to exhibit these biases. And then I'm actually very, very proud to present the first empirical evidence that I know of that actually shows that these biases that Kim described, myopia, over-optimism, are actually very prevalent in an actual sample of HIV clients. The context will be Uganda, but I think it can be generalized to a lot of settings. And that, moreover, these biases are not just prevalent, but they actually have an impact on adherence. So I'm measuring these biases at baseline, and then I measure adherence over the next 4 months, and I see that these biases, people who exhibit these biases at baseline, it actually predicts who will be a good adherent, who will show suboptimal adherence. Just like Kim, I will give some kind of broad stroke illustrations of what we could do with these insights, and I hope this will serve as a starting point for the discussion that will follow and that I'm sure Chris will chip in. So why do I think that behavioral economics matters for HIV research? Well, the first kind of very clear characteristic of, and most of what I'm talking about here, I'm talking about adherence because the study that I'll present at the end is about adherence, but you can think about condom use, you can think about prevention more generally, that share a lot of these characteristics. So the costs of pill taking are really immediate and they're grave. So you have to take your pills every single day, you have to associate that stigma and whatnot. The benefits of taking your medication are really very far into the future and somewhat intangible. It's increased life expectancy, improved life quality. So you have this disjunct in time, which makes it likely that people push it to tomorrow. So myopia, I always call it the tomorrow effect. Yeah, I'll do it tomorrow. I know taking my medication is important, but today I have to go to a wedding, so I'll do it tomorrow, kind of. The second one is that the benefits of ARV are really largely invisible. And what I mean with that is that, in particular, once people have taken their medication for a while, or for someone who has never been sick of HIV, if we think in the context of PrEP, there's really no benefit from taking your pill. You feel normal, you feel healthy, and yet you're taking a pill, which is a very different situation than if you are sick or broke your leg and you have to do something about it. So you kind of might forget that it's actually the pill that keeps you that way and keeps you HIV negative in the case of PrEP. So the salience or the information is not anchored in your mind. You might start forgetting about it, might slip your mind. The third characteristic that I think makes it really likely that people show these biases is that there's relatively little feedback over the course of being HIV positive. HIV is a chronic disease, it's a lifelong disease, and there's a lot of potential for unlearning. So people, for example, might not take the medication for a couple of days, but they don't fall sick immediately. So they might wrongly conclude, well, maybe I'm immune, or maybe adherence is fine if I take it every other day. So there's a lot of potential to learn unhealthy behaviors over time, and I think that makes it very hard to really, and it means that we have, and the plug to Dallas here, I really think that technology can hopefully help us re-educate people over this long period of time. It's not enough just at the beginning to say, you know that it's important to take your drugs, right? No, we have to do better and continuously inform people. And the fourth characteristic of taking your medication, just like going to the gym, you have to do it actively. You have to make the active decision of dragging yourself out of bed, going to the sink, taking your pill. So it's something you have to do over and over again. And as we already heard, people are overconfident in their abilities that they can do these kind of costly behaviors. And in my own sample that I will present in a minute, it seems that this is a really strong predictor also of those people who fail to adhere. So over the next 3 slides, I'll give you 3 biases, and there are certainly a lot of others that Kim talked about and a lot of others that I tested for my sample, but 3 key biases that we already heard of: myopia, salience, and overconfidence. And myopia, I found that about a good third of my sample, people in my sample, can be classified as myopic or impatient, whatever you want to call it, or present biased. And I think the interesting point here, and one of the hopefully takeaway points here, is that we identified myopic people with a single question. We simply asked them, do you want $10 now, or can you wait a month and I'll give you $20? That was the simple question we asked. We didn't do a whole battery of questions or whatever. It was one simple question. We found that those people who want the money now, who are impatient, had 15 percentage points less, they were 15 percentage points less likely to show 90% adherence. I think that's quite kind of striking that such a simple question predict the low adherence in this way. And of course, this is not definite evidence. This is a first and novel evidence. So we'll test it. But there's actually a second study that I'm involved in that shows that the same kind of question predicted mortality in another HIV sample. It's also not published yet. So what do we do in a situation where it seems that it's not just hypothetically or intuitive that people living with HIV might be myopic and might fall prey to myopia, but where we actually find that a lot of people display this? I think clearly rewards are one thing that we want to think about. And again, maybe technology can help us really bring these rewards forward. And one of the applications of how one could do this will be at the end, where I talk about an actual study where I tried to address myopia in a sample in Uganda. The second bias that I want to talk about is overconfidence. And my sample in Uganda were selected based on having demonstrated adherence problems very recently in the last 6 months. And despite the fact that they all had adherence problems in the recent past, a full 90% of people thought that they would no way that they would forget a pill in the next month. And 20% were even so confident in their capability of taking their drugs that they said, I can beat the average client, the other clients at the clinic. They thought that despite their showing adherence problems, they were better adherers than most people at the clinic. And for these 20% that are so very confident in their ability to adhere to medication, again, we found that these are exactly the people who showed low adherence. So again, with this simple question, we were able to identify people with suboptimal adherence. So what can we do if people are so over-optimistic? One thing I think is information provision. I think when we think about information provision, we often think about, taking your medication is important. And when I ask my people in Uganda if they think that HIV is serious, they say yes. Do you want to adhere? Well, yes. But somehow this good intention does not translate into good actions. So I think we have to do better, again, in terms of giving people feedback, informing them, and helping them achieve what they already want to do themselves, but somehow fail to do. The third and last slide and bias that I want to discuss is salience. We already discussed that most people know about the benefits of ARV, for example. But knowing doesn't seem to be enough. Seems that information has to be somehow locked in your brain recently. So we ask a simple question: in the last month, have you talked to someone about the positive benefits of ARV? Has someone told you about them having good experiences, or have you told someone else? And about a third of the people did that. And again, that third of the people showed 17 percentage point higher adherence than the other ones. So again, simple question, but very targeted ones, and we, again, were able to identify suboptimal adherers. And here, salience is really a hard thing, I think, for chronic lifelong disease such as HIV. I mean, people, on the one hand, don't even want to be reminded every day that they're HIV positive. So how do we make it visible, but also visible probably in a way that is acceptable to people, right? We don't want to call people every day in the morning and say, you're HIV positive, you know that, right? So I think to make things more visible, I think we, again, can look at also technology. And Amy asked you about the Fitbit part of it. So we could, for example, think, how would a Fitbit for HIV look like? A Fitbit measures steps that we take towards the relatively invisible benefit of losing weight. How would a Fitbit for demonstrating good adherence or for demonstrating the benefits of ARV look like? And just one quick slide so far I have talked about why I think that behavioral economics matters for HIV. I have shown you that in an actual sample of HIV clients in Uganda, these biases are prevalent, and that moreover, they have a huge impact on adherence. So, but behavioral economists don't just sit there and say, well, these people, they're pathological. But behavioral economists recognize that this happens to all of us all the time. So behavioral economists then turn around and say, given that most people or a lot of people exhibit these biases, how can we turn around and use these as intervention and entry points to an intervention? So what I did is that I observed in Uganda, an HIV clinic, that there's a lot of treatment fatigue, that people are aware that they should take their medication, but somehow it has become such a drag basically to do that I thought about how can we provide some sort of fun incentive to get them again to show good adherence. The other observation is when you walk around Kampala, the capital of Uganda, everybody plays lotteries. They buy scratch cards. Every Coke can has some sort of prize drawing on it. So I said, why not do an adherence lottery where people have to basically buy tickets by showing good adherence? And that's exactly what I did, a very simple idea. And it is somewhat similar to contingency management in that there were rewards for good adherence, that every time the client came to the clinic and showed good adherence, he was eligible to draw basically a prize out of a hat. But what we really did was not to focus on the monetary reward. And you will see that even in the context of Uganda, the payouts were minimal. We paid about the expected payout is about $2 to $3 per person per year. So people can win a coffee mug or they can win an umbrella. So the cost of running this is extremely, extremely low. And the other thing that we did is that we really de-stressed to the clients. We didn't say, I'm going to give you money if you show good adherence. We told them, we know it's hard to take your medication, and we want to help you, and here's something fun and exciting that hopefully will help you do that, and maybe you can also beat your friends in winning a prize. And after 4 months, I've got the first 4 months of data now, I found about a 12 percentage point higher chance of 90% adherence in the intervention group compared to the control group. This is a randomized controlled trial, a small one, but we're finding a pretty large impact given this small payout. And just my very quick slide to wrap this up. What I'm thinking I'm addressing with this adherence lottery, it's kind of a test for you of what you've learned so far. So obviously we're addressing myopia, and that's kind of the contingency management part of this intervention. We're providing rewards much more frequently than the increased life expectancy and improved life quality. We're also making use of loss aversion because we tell people if they come in and they don't show good adherence, we tell them, wow, look at these nice umbrellas we have there. You could have won one if you had shown good adherence. And actually your friend yesterday won one. We're making use of optimism and overvaluing of small probabilities because people, which means that people prefer lotteries typically over fixed payments, and also leads them to actually engage in the program because they should know that they are typically not good adherers and shouldn't even buy these lottery tickets, but we all do, right? And the last point, as I said, we really de-stressed the monetary part and really focused on this effect part and created a fun and exciting mood of participating in this, which I think really links also to something that is very often criticized of any rewards programs, that it's about the extrinsic motivation. But we really tried to leverage the intrinsic motivation. We said, you know, we know that you know that it's important, and we want to help you achieve your goal and not, you know, do what we want and then we'll give you money. So I'm going to stop there and hope to get interesting questions from you. Thank you.